Disc 2 concludes with a discussion Allan Jaffe had with Dr. Barry Franklin, head of preventive cardiology and rehabilitation at the William Beaumont Hospital in Royal Oak, Michigan, on the role of exercise following acute coronary syndrome.
Welcome, Dr.
Thank
Franklin.
you, Dr. Jaffe.
I would think that most clinicians would be concerned about the safety and efficacy of exercise, at least soon after an acute coronary syndrome. What are the data in that area, Dr. Franklin?
Dr. Jaffe, a great number of studies now suggest that the risk of exercise is extremely low. In fact, the latest research suggests one event, usually non-fatal, out of every 59,000 patient hours of exercise. So it's extremely low. And in fact, the latest studies suggest that cardiac arrest is successfully reversed in more than 90% of all cases in a medically supervised environment. So it's extremely safe.
Is it effective?
Highly effective. We now recognize that a modest exercise program can typically improve the patient's aerobic capacity by 1 to 2 METs, and we typically now suggest, or the data suggests, that each 1 MET increase transforms to about a 15% reduction in cardiovascular and all-cause mortality. So it's highly effective, similar to what you might do in terms of beta blockers or aspirin in terms of the magnitude of effect.
Wonderful. So how do clinicians get patients to participate? Sometimes that's a very difficult task, and sometimes there's a facility available that facilitates that, and sometimes there isn't. But how clinicians to pose this to patients, and how do we get more participation?
Very simply stated, increasingly physicians have to address exercise and physical activity habits. Dr. Phil Ades, University of Vermont, a good friend and colleague, has published on this extensively and said the single most important factor that determines a patient's participation is a strong recommendation from their primary care or cardiologist. And then there are 2 roads a patient can go: home-based programs or supervised programs. Typically, we recommend the moderate to high-risk patients get involved in medically supervised programs.
What are the metrics of those programs, specifically about things like assessing functional capacity at baseline, the prescriptions, and how much exercise we ought to suggest patients do? Those sorts of key metrics that we ought to focus on.
Years ago, we used to think everybody's got to have a peak or symptom limited stress test prior to cardiac rehab. That's really passé. We no longer say everybody's got to have that. And oftentimes, we'll recommend some submaximal level of test, or in many cases, our patients may complete what's called the DAISY, a Duke Activity Status Index, 12 questions, which gives us yes and no answers, a fairly good index of what their functional capacity is to begin with. Secondly, when we prescribe exercise, we have to address the mode, the intensity, the frequency, and the duration. Mode is generally aerobic exercise, walking, jogging, cycling. The intensity generally corresponds to 45 to 85% of the peak aerobic capacity. Perceived exertion corresponding to a perceived exertion of roughly 11 to 14, which is fairly light to somewhat hard for the patient. In general, we recommend 3 to 5 days a week of exercise. We also recommend 20 to 60 minutes of exercise per session. Dr. Jaffe, in general, the longer the exercise, the lower the intensity. So patients who are exercising at higher intensities might do 20 minutes or 30 minutes just 3 days per week.
Are there issues in regard to safety that clinicians ought to focus on in developing this sort of exercise prescription?
The first thing we do is educate patients in terms of warning signs and symptoms: unusual chest discomfort, unusual shortness of breath, lightheadedness, palpitations that the patient may be experiencing. Secondly, what many people don't realize is the highest risk group is what we call the bottom 20%, the least fit patients, the 3-4 METers or less. So if we can just start those patients by walking and gradually increase their fitness, they markedly reduce their risk of a subsequent event. Oftentimes, number 3, we find that people who engage in sudden, unaccustomed, vigorous physical activity, going out and shoveling snow, playing racquetball with your son-in-law and you haven't played in 20 or 30 years, these are the people who more often than not run into problems. Account for environmental conditions. If it's hot, humid, or very cold, we've got to dress appropriately or adjust the workloads. And last but not least, as we do in our programs at Beaumont, we adjust recreational games for our cardiac patients. For example, we play volleyball, we allow one bounce of the ball per side. Whoever invented volleyball would turn over in their grave if they saw us play that, but we can take guys that are 3, 4, 5 Mets and make them an instant success at volleyball by modifying game rules slightly.
Are there other things to maximize safety? Do we need AEDs? Do we need observation in many patients? How does one balance those sorts of facility versus non-facility circumstances?
I feel very strongly that individuals with a history of coronary disease are clearly at higher risk, especially if they're involved in vigorous physical activity. An AED today is $1,500 or less, so it's unconscionable to have an exercise facility or a public recreation facility without an AED available. There's no question that when somebody is exercising, they're at higher risk for an acute coronary event, and to a large extent, it depends on their habitual level of physical activity. If a person's a regular exerciser, their risk may increase twofold. If they're a non-exerciser and they do vigorous exercise, the cardiology literature tells us their risk may increase more than 100-fold. So the relative risk can increase substantially, and therefore an AED, I think, is absolutely essential to have. We actually, in our programs at Beaumont, also use a defibrillator and put the paddles on the chest so we can look at a spot ECG for those individuals who we suspect signs or symptoms of myocardial ischemia or intensity violators.
Would you do the same thing about the patient who has a home-based program that you've prescribed?
Generally, for our home-based programs, there is some telemetry monitoring that could be utilized. On the other hand, for home-based programs, we generally reserve those for low-risk patients. That is, patients who have good left ventricular ejection fraction, patients who generally have higher MET capacities, and oftentimes these are patients who had a recent stress test which did not show any malignant ventricular arrhythmias or signs or symptoms of myocardial ischemia, so the need for ECG monitoring is less necessary.
Most insurers will pay for 10, 12 weeks worth of rehabilitation, but thereafter there obviously is potential for some improvement as well. How do you get patients to transition from a more formal program to more healthy habits on a daily or weekly basis to preserve the benefits that they've acquired through the initial exercise prescription?
Dr. Jaffe, that's the million-dollar question. There's no question about it. Compliance with lifestyle change tends to be problematic in secondary prevention programs. What I recommend is that cardiologists address at every visit the physical activity habits of the patient, because if it's coming from the cardiologist, just like taking your beta blockers, just like taking your statins, then it has more emphasis to the patient per se. Secondly, I believe that to a large extent, exercise should be fun and enjoyable. So if we can find recreational activities that the patient truly enjoys and can work at a 2, 3, 4 Met capacity, which is a sufficient stimulus for training and improving fitness, that in and of itself is very, very helpful. Lastly, the social support of getting involved with other people, either in a cardiac rehabilitation program, a neighborhood group, that goes a long way in terms of maximizing compliance.
Are there things that we as a society ought to do, could do, to facilitate better exercise behavior on the part of all of us, including patients with acute coronary syndrome?
Well, I'm actually working with the governor's office in Michigan because I think to a large extent, part of this is what you're referring to is our environment. Our environment is not conducive to being physical activity. So we're talking about building new communities and getting sidewalks back in those communities. We're talking about the possibility of building communities that somebody could walk a mile or 3/4 of a mile to a neighborhood store. To a large extent, people take the car instead of walking or bicycling. And clearly the cardia study showed if you commute to work, your risk factors are much, much lower.
Are there ways that the average cardiologist and or patients could interdigitate and help you with your efforts in that regard?
I think increasingly one of the reasons I'm at the cardiology meeting is to emphasize the importance of regular structured exercise or increased lifestyle physical activity as an integral part of the secondary prevention armamentarium, and I feel very, very strongly about that.
One of the confounds of evaluating exercise after an acute coronary event is the fact that the people who usually are pretty compliant and are pretty good exercisers are already apt to enroll. So you enroll a lower risk group and a group that's more compliant. And so it's hard for clinicians to push that other group, which is less inclined to do that. Are there data about that other group as well, and about how we get them to participate and what their risks and benefits are?
That's an excellent question, Dr. Jaffe. To a large extent, it's not the cardiac patient who's got a 10 Met capacity who goes up to 11 Mets who gets the most benefit. It's the patient who's got a 2 or 3 Met capacity and gets over that 4 or 5 Met level who stands to gain the greatest benefit. In other words, getting people out of what we call the bottom 20% or lowest quintile into the below average fitness. To that extent, I think sometimes we rely too heavily on national guidelines, 30, 60, 90 minutes, when in fact even 10 minutes 3 times a week may oftentimes move somebody from a 3 or 4 Met capacity to a 5 Met capacity, which can have a huge public health benefit. So those are some of the things that I think we need to emphasize to get the biggest bang for our buck.
Are there informational places other than ACCEL where people can get additional information if they're interested?
Well, certainly the American Heart Association has a number of resources, as does the American College of Sports Medicine when it comes to exercise interventions, both primordial, primary, and secondary prevention.
Well, this is a terribly important topic, and I hope you'll come back and update us in the future about the results of these sorts of interesting interventions. Thank you very much.
Thank you, Dr. Jaffe.
And that brings us to the end of Disc 2. For details about studies discussed, refer to the written summary that is included as a PDF file on Disc 3, which begins with a discussion on how the ACC Science and Quality Division assists the cardiovascular practitioner.